Good afternoon, my lady. May I please...
Sorry, I overspoke. Good afternoon.
May I please call Albert Heaney?
Stand and take the information. Just repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Take a seat.
Good afternoon, Mr. Heaney. I hope we haven't kept you waiting too long.
Not at all. Thank you very much, my lady.
Thank you, Mr. Heaney. You're here today to give evidence in relation to the role that you played during the pandemic. And may I just confirm, you are now the Chief Social Care Officer for Wales.
Yes, indeed.
And I'm just going to go through a little bit of your background. I'm not going to go through it in detail because it's set out within your very helpful witness statement. But in short, you began working as a social worker within a local authority in Wales all the way back in 1980.
1988.
1988.
Yes.
Thank you very much. Since then, you've held various wider roles, including the President of the Association of Directors of Social Services, Cymru, ADAS, Wales, is that correct?
Yeah, indeed.
Lead Director for Children, Lead Director for Safeguarding and Prevention. You've chaired numerous boards and committees with regard to safeguarding and adult protection, and been the Corporate Director of Social Services leading on children's and adult services.
Yes, that is true. Thank you.
And immediately prior to the pandemic, you were the Director of Social Services and Integration within the Welsh Government.
I was indeed.
Turning to your role then in the pandemic, and I'm really focusing now on your role between March 2020 until initially June of 2021, you were the Deputy Director General to the Health and Social Services Group. Is that correct?
That's correct.
And you were the Deputy to Andrew Goodall. Is that right?
Yes, that indeed.
And then in June 2021, you became the Chief Social Care Officer, along with the Director of the Social Services and Integration. You held those real roles concurrently.
Yes.
Thank you. In terms of how that sat within the Welsh Government, I just want to break that down a little bit because on the face of it, it looks a little bit complicated. So in terms of the Welsh Government, we have the Minister for Health and Social Services, who holds responsibility for adult social care.
Yes, indeed.
That was Vaughan Geffin until May 2021, and then Eleanor Morgan.
It was.
And then in addition to that, there's also a Deputy Minister that focuses on social services, and that was Julie Morgan throughout the relevant period.
Yes, indeed.
Here, what we're concerned with is the Health and Social Services Group that reported in to the Minister. Is that right?
That's correct.
And at the time, as I've said, that the Director General there was Dr. Andrew Goodall, succeeded by Judith Paget.
Yes.
And at that point, and this is relevant to why your role changed, Dr. Goodall was also Chief Executive of NHS Wales. Is that right?
Indeed so.
So he held these two positions, and as a consequence of that, that's one of the reasons why you were made Deputy Director, to take upon some of those burdens and those responsibilities.
Yes, Deputy Director General to support him in his capacity.
And the Social Services and Integration Directorate is one directorate within the HSSG.
It is indeed.
And that is responsible for policy within the adult social care sector, but it's not responsible for delivery and implementation.
No.
And whose responsibility is that?
The responsibility for the delivery then for social care in Wales rests with the 22 local authorities.
Thank you. And in relation to the Social Services and Integration Directorate, that had 3 divisions, but in addition to those, during the pandemic, there was a social care coordination hub created. Is that right?
Yes, indeed.
Was that a new structure, or was that one that was envisaged pre-pandemic with regard to potential pandemic or emergency situation use?
That was a new structure designed to respond to the pandemic.
Thank you. And that had various work streams, and we're going to touch on some of them, but testing, PPE, vaccination, visiting, all of those types of areas.
Yes, so although it may not lead on all of those policy areas within the group, they were clearly areas of interest and importance to the Directorate.
Thank you. And when you say you may not lead on those, so what we do have are other government departments and groups leading on those different issues, you providing support or collaboration on your specific areas of expertise.
Indeed, and also ensuring that the social care perspective is then understood and taken into account.
Thank you very much. Turning then in relation to the adult social care sector, could you just provide us with a short summary of how you saw the sector at the point of when the pandemic began? So we're looking at back between January to March of 2020. Just a very short overview.
Yeah, thank you. Thank you for the question. My succinct overview would be it was a very fragile system, high turnover of staff, social care staff, very low paid workforce, and therefore went into the pandemic in a fragile, more vulnerable state.
Thank you very much. And just looking at capacity within the adult social care sector, were there concerns with workforce capacity? Were there sufficient members of staff effectively to occupy that sector?
In terms of sector, it's a very fragmented sector. So it has local authority provision, it has private providers, independent sector, and it is fair to say that staff. Workforce staff turnover has been a constant challenge to the sector. So it's a struggling sector going into it in terms of workforce.
Thank you. Now, if I can just turn then to preparedness in relation to the pandemic, you set out in some detail, actually, the various exercises that the department and the government, the Welsh Government, were generally involved in, and those that pertain specifically with aspects of adult social care. I'm not going to go through those in great detail with you, but what you do explain is that aspects of that was paused owing to Brexit preparations, and that's something that my ladies heard about previously. But in relation to the pandemic planning at that time, again, as we've heard in other modules, that was predominantly focused on pandemic flu. And the primary pandemic preparedness group was the Wales Pandemic Flu Preparedness Group. And that last met prior to the pandemic in November of 2018, is that right?
That is true.
It reconvened then in January of 2020. And if I could just call up INQ 000180621, please. We see here a 23rd of January paper that was prepared for that purpose. But can I just be clear about this? It does not appear that this is actually connected to COVID-19 specifically. Is that right?
That is right.
There's no mention of COVID-19, so this is really talking about general contingency planning at this point.
Yes, indeed.
It states countermeasures and consumables to meet the planning assumptions. There's a reference to the PPE stockpile. There's a reference to work streams. We see healthcare demand, where they talk about surge demand for critical care. And in that regard, hospital discharge was always envisaged. Is that right?
Yes.
We see adult social care demand, again, surge, resilience. But whereas healthcare is specifically mentioned, if I can go to 003, please, where we see that healthcare is specifically mentioned, there is no mention of adult social care there at all, is there?
No.
And the remainder deals with excess deaths, communications and legislation. And as I say, don't intend to go through any of that in detail. One consequence of all of the planning being based on pandemic flu was that you said that the guidance that had been produced was not designed for an emerging disease pandemic lasting more than 2 years. To your mind, does that represent a lack of preparation for the sector?
In my mind, it represents a focus on a certain type of pandemic, But once we moved into COVID-19, then the requirements and demands were very different to that preparation. And indeed, I think that is potentially a real learning point for the future.
Indeed. To what extent, therefore, were the existing plans for adult social care adequate?
They were adequate in so much as, had it been a pandemic flu that we were dealing with, then I think it would be fair to say a great deal of thought had gone into that across the sector. But in terms of the COVID-19, then I think my view would be that that preparation didn't enable us to be well placed when the pandemic took place.
In terms of practical consequences, did that mean that you were not quite starting from scratch, but certainly had to begin in terms of guidance and policies from a very different starting point to what we'd hoped to have been envisaged?
Yes, indeed.
If I can just talk, therefore, now to move to the pandemic itself. I don't know if you can help us with this at all, but on the 25th of February of 2020, Public Health England produced guidance for the care home sector. Are you aware as to whether or not the Welsh Government did the same?
By that date, I believe our guidance began to emerge in the March period.
Thank you. Now, if I may, I'd like to talk about, or to ask you questions rather, about the hospital discharge policy and care homes. So at the outset of the pandemic, as we've discussed, it was always envisaged that that would be a potential route in terms of relieving pressures within the NHS in Wales. There was draft extreme surge guidance included as part of the Paul's pandemic planning. That was later to be published in relation to COVID in April of 2020. But again, is it right that that did not provide any guidance to the adult social care sector on how to accommodate discharges or any relevant IPC infection prevention control measures?
In relation to the surge guidance, I think there was some helpful issues and support in that guidance for social care. I believe that from memory of the guidance and from the conditions at the time, that it was focused on some of the key issues that would have emerged around pandemic planning, but with the early day learning around what COVID-19 was transmitting, etc.
But there was no specific guidance contained within that in relation to the adult social care sector, was there? As in specific guidance as to what they would do in the event of a discharge?
Not in terms of discharge. There was guidance, as I said, in there that I think was helpful to the social care sector. The hospital discharge guidance then comes, it is separate to that. Yeah. Yes, and you'll have the dates of that, of course, within my statement as well.
Thank you. Now, turning then to the 13th of March, that was when Mr. Geffin announced the framework of actions. Yeah. One of those actions, of course, was to expedite the discharge of vulnerable patients from acute and community hospitals. Now, in relation to that, a ministerial advice was subsequently produced around a week later on the 20th of March. Why was there a need to produce that retrospectively?
Well, we would be, as a government, we would be preparing ministerial advice. So there's a record of this decision. I think that in relation to the framework announced on the 13th of March, that predominantly that was a system response from the NHS in Wales, and therefore from a policy perspective, that advice did follow informal advice up to the Minister shortly after that announcement of the framework.
Thank you. If I can just look at that with you for a moment, that's INQ 000366593. We can go to page 3, please. This sets out the hospital discharge policy here. And what we can see is the need to expedite. Yeah. It says, and in relation to that, the other actions are to relax regulation requirements, to commission vacant nursing and residential home capacity, suspend the choice protocol. That relates to an individual being able to have a choice, effectively, of which care home or facility to go to. And then easement of social work hospital discharge assessments. Now, just dealing with that, what we do not see there or any, and more broadly within this, or mention of any risks in there to care homes or patients, the residents in care homes? Would you agree?
So this advice, of course, is not my policy area. I did not lead on this. I'm sure it's important to just clarify that today. I think that this was very early thinking from the NHS, understandable in the circumstances, knowing that they were in a very difficult position with the reasonable worst case scenario, knowing what they knew at the time around what was coming their way in terms of demand for, acute healthcare. Within this then, and answering your question, there is limited in terms of statements around the adult social care sector. But of course, that was then quite quickly where, as a government, as a team, we were involved with other colleagues, medical and scientific.
And really what I'm asking about here is that the advice that's been written in relation to hospital discharge focuses on the issue of discharge from hospitals and creating capacity. What it doesn't do is look at it through the other end of the lens, with those individuals being taken into those care homes and what challenges and risks those care homes might face. Is that a fair summary?
That's a fair summary.
Thank you. Now, in relation to discharge of individuals with symptoms, you provided your advice and views, and I just want to draw up an email that you sent in relation to a query from a care home, and that's INQ 00336 and it's going back to the 23rd of March. And if I can go to page 3 first of all, please. Thank you. And as you can see here, it's a query that's coming up in relation to patients from what they consider to be a COVID-19 positive hospital. So we can take from there's been at least an outbreak, or they have diagnosed COVID-19 patients within the hospital. And there's a query coming up because they're not showing symptoms, but the home feel that to protect the 69 people they have, that new patient should be either isolated or tested, and they're concerned that no testing is also available for staff who is ill. That comes up, and if I can go back to page 1, please.
Yeah.
And we're asked initially if Public Health Wales, who the Public Health Wales contact would be. Were they involved in this?
They were involved. They were involved because at that time we were very committed to producing discharge guidance that would support care homes.
Thank you. If I can scroll up to the top, please. What you have to say about this, and it's progressed onto a conversation about symptoms as well, is you say, I don't think we can say do not admit with symptoms as the health service will collapse within a day. And you say, wouldn't this be self-isolation and PPE, and you're happy to discuss? So at this point, the overarching priority from your perspective is to discharge individuals, because otherwise the healthcare system may well collapse if you're met with those sorts of objections.
So this was a very difficult time for families, for loved ones. We had very clear advice, medical, scientific, that we could safely discharge from hospitals to care homes, but not without having, as I've mentioned here, some safeguards in place to protect people, as I've highlighted, PPE and self-isolation.
And in relation to those with symptoms, we see that there was indeed guidance in relation to self-isolation and individuals wearing PPE were there to be a COVID positive patient discharged. But in relation to those individuals who may not have been presenting with symptoms, there was no such guidance.
Well, the advice at that time, and that's important to look in terms of the history then of, the very complex history of asymptomatic, symptomatic. The advice at that time was that for asymptomatics was that we didn't need to do anything at that particular point in the cycle of COVID-19.
So at that point, what
Yes.
you're saying is that the advice was that there was no concern in relation to asymptomatic infection or more to the point, transmission.
And as we see it develop, we see that change over the next, I would say, 6 to 8 weeks.
I'm going to return back to the issue of asymptomatic in due course. But do you now consider that there ought to have been guidance in place? Looking back in hindsight, I appreciate from your perspective, but also looking to the future, to isolate all admissions from hospitals as a precaution.
I think it would be very difficult to say today that at that moment in time there should have been a different approach based upon the medical and scientific advice we had. But of course, I mean, as part of this process, I'm always keen to see what we could learn and do differently. And I think when you come on to asymptomatic, there may be some comments that might be helpful reflections that I can make.
Thank you. Now, in terms of those care homes that may not have been able to isolate, because of course different care homes have different capacities and capabilities, ought there to have been consideration of isolating those residents in other settings, as became later the position as of around the 29th of April when step down was introduced?
Well, certainly at the time, as I've mentioned already, it was a very difficult period for everyone. There was, the prospects of, hospitals being overrun. And it wasn't just about protecting hospitals. That was about protecting life. So these were very, very difficult judgments and calls to be made. And, anyone affected by that, I've always felt very deeply, and my condolences to each and every one affected during the pandemic. But I think that, when we look back now, potentially that, as we term it, as we often use jargon of step down facilities, I think that would be a really good thing going forward. So the earlier we could introduce that, I think that, to me, is a real learning point from this experience.
And turning to testing and prioritisation of testing.
Yes.
Because at various stages there was scarcity of testing and prioritisation had to take place. Professor Core told the inquiry that Public Health Wales did not have access to the number of hospital discharges to care homes, so they didn't have access to that data source. Now, they were also at that point advising on testing and allocation of resources. Is that right?
Well, at that point, they would not have had that information,
No.
Indeed.
But they were the ones that were also advising on it, on how to use the tests that were available.
Yes.
Should ought that information to have been provided to Public Health Wales at the time to inform that advice?
Well, I think it would have been better to have that information available. That information would have been held, I believe, at a local health board level. And indeed, there was modelling then undertaken retrospectively quite quickly. And I know that, for example, the NHS assisted in that modelling, and that was shared with partners.
You'll be asked further questions about capacity in due course in relation to hospital discharges. But certainly with regard to those data flows, that's something that, would you agree, needs to be put in place if it has not already?
Yeah, the data flows around social care certainly have improved since the pandemic from our learning, but there is no doubt that data and information was a very weak area that did not help us at the beginning of the pandemic.
Okay. And it wasn't until the 24th of March, moving slightly forwards now, that Public Health Wales were asked for advice to provide a letter of guidance, essentially, to the care home sector in relation to accepting admissions or returning residents, those residents that had been taken to hospital and then were set to return to their care home. So at the time of the framework of actions, obviously sometime before, is it right that there was not yet any guidance in place for those care homes?
Well, those care homes would already have standard guidance around infection prevention controls. The Public Health Wales, to their credit, also had set up a what I'll term a kind of a national contact centre as well for care homes, care home providers to be able to contact. So it wouldn't be that they would be operating in a system where they wouldn't be used to having, and they have advice and standard procedures around infection prevention controls. Obviously, COVID, as we know now, was a different type of virus as we journey forward.
Indeed, and obviously the framework was set out on the 12th.
Yeah.
And then we're talking now about the 24th of March.
Yeah.
By that point, the 13th of March, and now we're talking about the 24th of March. But by this stage, consideration had not actually been given, had it, to care home specific advice in relation to COVID and the discharge policy.
No, care home, and that was the advice that I wanted to see.
Indeed.
Yes.
Why was there that delay?
I think, in hindsight, difficult to give a precise answer today. My experience was just the sheer speed of things that were happening at that particular time. But as I say, care homes did have advice and had advice available to them at that time. So it wasn't that they were operating in a total vacuum to standard operating procedures.
Now, in terms of your communications and the way in collaboration between the various agencies, between your directorate and Public Health
Yes.
Wales, you and indeed Public Health Wales speak of various challenges that were encountered with confusion as to who held what responsibility in some respects,
Yeah.
which individuals were the correct individuals in terms of what responsibilities and roles they held, and frustrations, in short, becoming evident in relation to progressing guidance, progressing advice for the sector. Is that a fair summary?
It is a fair summary, and one of my learning points here on reflection is, if we were starting again, would be to really ensure those points were clarified. And I think as we journey through the pandemic, there's evidence that we did improve that communication and flow between those us as partner organisations.
And there were certainly frustrations evident on your director's behalf in relation to the speed and pace at which Public Health Wales were working and operating in relation to guidance. Can you provide a little bit more insight into that?
I think, depending on where your questions go next, and I don't want to preempt, but I think there were critical points where we probably found ourselves in either a misunderstanding or different position. But you are right to say there were at times frustrations, I'm sure on both parts. But equally, we were, from my seat as lead around social care, I was just really keen that we could get information, good information, quality information out to support the sector as soon as possible.
And we see that one example of that actually in relation to the hospital discharge guidance. And if I can just call up 000336353, please. And if we can go down to the second paragraph, initially what we see here is I'm trying to progress this with Public Health Wales, not getting very far, it's extremely frustrating. Obviously there are conversations then that are referenced with you speaking to different individuals also. And then what we have is I heard separately yesterday that the Chief Executive of Public Health Wales is planning to write a joint letter with someone from Welsh Government, WG, I assume Albert, you, to all care home providers covering admissions and a range of other issues, trying to work out whether it's the guidance that they have their team working on or there's a risk of duplication. And so this is an example of the issues that your team and indeed we've heard some evidence, I say, from Public Health Wales, we're dealing with at the outset. But do you accept that those sorts of issues could have had a real impact upon those care home providers who were struggling in the absence of specific sector guidance?
I think for care home providers, one of the real learning points through the pandemic was for them and their staff, they were a real credit to the profession. The things that they did, they went above and beyond. There were many really good illustrations. And I think, without a doubt, this is a matter of days sometimes. But from my perspective, the earlier, as I've said earlier, the learning from this is the earlier. If you could bring everything forward, that would be a good thing as a learning point for any future pandemics that we may face.
And in terms of future pandemics, Has there been any thought given as to how you'd approach that in the future to ensure better working, better delineation of roles and good communication so that you can get guidance out swiftly to a sector that needs it?
Yes, indeed. And of course, the only caveat I would say to that, which there is one, is that a lot of the people I've worked with during the pandemic, they already moved on. So the learning about the experience of the pandemic, I think, from this inquiry will be invaluable to us all in terms of what we do in preparedness for the future.
Now, just dealing with some evidence that we've heard from Public Health Wales, they explained that in relation to this, there should not have been any confusion because as far as they were concerned, they had a clearly identified incident director rota, and that rota was available to the Welsh Government. Was that rota available to you and your team within the Welsh Government?
Certainly, I can't recall seeing that rota myself personally.
Now, if I can turn then, please, to slightly later. On the 2nd of April, the UK government published its guidance on the admission and care of residents in care homes. Public Health Wales's guidance was not published until the 8th of April. Do you know why there was that delay, that further delay?
Well, that's very much on the point that you've just been questioning me on. It's to do with, working through the detail, points of clarification, and, the guidance was then issued on the 8th of April.
And if I can just touch now in relation to something that you say in your witness statement, it's at paragraph 308. And it's dealing with the issue of testing.
Yes.
You say it was clear that if discharges were not made, hospitals would not be able to function effectively. And we've seen that already from your emails at an earlier stage. And you said, in the absence of advice to the contrary from health experts and evidence regarding asymptomatic transmission, while testing of all patients would have been preferred, without sufficient testing capacity, it was not possible. So what you're saying here is, ideally, it would have been good to have tested everybody, but insufficient capacity. Is that right?
Well, I think there are 2 points to clarify here. One was the science and the medical advice was still indicating very strongly around who to test and who not to test and what was required. My professional view, of course, is that the earlier we can use testing to build confidence, get a clearer picture, manage COVID-19 would have been my preferred choice. But of course, you will see, and you will know this very well, I'm sure, but from my perspective, the testing capacity takes some considerable time to really allow us then to do that wider base testing that begins to emerge in the May and June period.
Indeed. What I want to focus in on, if I may, with you, is in terms of your view that testing would have been preferable, but you didn't have sufficient testing capacity. At this time, firstly, was the decision not to test made effectively on scientific advice that you shouldn't test, or was it made on the basis that it would have been desirable to, but we don't have capacity, so we have to prioritise?
It was made based upon the medical and scientific advice.
And so is that your view in hindsight, effectively? It would have been preferable to have tested, but we didn't have capacity.
That would be my view in hindsight, it would be.
Now, in terms of further hospital guidance that was published on the 7th of April, Professor Kaur again told the inquiry that that PHW was not consulted, and it would have been helpful to, because of course it involves their roles and responsibilities. Do you know why they weren't consulted by that point?
Could you just repeat that question, please?
Of course. So there was hospital discharge guidance that was produced by the Welsh Government. That's why I'm asking you about it, as opposed to the NHS, dated the 7th of April. And Professor Kaur explained that Public Health Wales was not consulted in relation to that. Do you have any understanding of why that would have been?
Well, the guidance that was published around the 7th, 8th of April was guidance that certainly my understanding was that Public Health Wales had been cited on that guidance.
Would you have expected it by that point? Were those earlier issues about communication ironed out at this stage, or were they still there?
Well, in the early, I think the communication issues, possibly there was some points to, between the March and April period, but by May we begin to see that moving forward. But certainly on that guidance, I'm happy to be corrected afterwards, but my understanding is I think Public Health Wales were cited on that particular guidance. But that again may reflect the different communication channels within Public Health Wales.
Well, Professor Call explained that from his perspective, the policy decisions of the Welsh Government remain quite unclear for some time. And that was escalated up the chain to you at one stage. Do you recall it by way of an email? And if I can call that up for you if it would assist. It's 499632. And what we see, it's under the word a few points, so about a third of the way down, first bullet point. Several references below to not having clear steer or instruction from the Welsh Government. Been provided in emails to PHW from both Marion and I, from Alison. It was reiterated at the meeting this morning. However, Andrew kept saying that from a meeting he'd attended yesterday, this was not Vaughan's position. So were you reliant at that point still on just discussions and emails as opposed to formal structures and communications?
So the earlier question related to a different guidance, which I'm pretty certain they had sight of. This relates to a change in our knowledge around testing on discharge. You will have seen Tactical Advisory Cell had met, I think, on the 14th of April date, and had certainly from Sage and others begun to understand more around discharge into care homes from hospitals. On the 15th of April, the policy changed in England, an announcement to test all discharges into care homes from hospitals. And at that point, both myself and the CMO wanted a change in policy. So this relates to that request. That request went in an email on the 15th and then was followed up in a further email from the CMO's office by Dr. Marion Lance on the 16th. So that's what this relates to at that point.
My question in relation to it is just that these problems were continuing. I'm going to turn to the 15th guidance in a moment. But this is an indication of still, at this point, those issues are continuing.
I think that's absolutely correct, and I've acknowledged earlier we would want to do that differently. But I think on this occasion, just to say from a policy perspective, I think we were clear on the 15th, and I think we were clear on the 16th.
Now, turning to the policy implemented on the 15th of April, as you say, to test all discharges from hospital, that took some time actually to be implemented, with the guidance being produced effectively 2 weeks later on the 29th of April. Now, it's been accepted that there was obviously that delay by the Welsh Government. Why was that policy not implemented immediately rather than waiting for updated guidance, which obviously took some time?
Yeah, and I think the first thing to say is, look, we are deeply apologetic for the length of time that took. I know that I was personally concerned at the length of time at the time. And, in terms of the experience for anyone who suffered during that time, I on behalf of Welsh Government, are deeply sorry for that. The reasons, I think, are, to me, related to actually Public Health Wales, our communication with them at the time. Clearly, as I've mentioned, I think that's a learning point for us all. But we were asking Public Health Wales around, testing capacity, which they were, in a sense, the custodians of. So I think there were questions that we needed to answer, to understand, to work through, and some of that took a lot longer than I certainly would have liked to have seen.
And my question is really, why did you just simply not implement that policy rather than wait?
And I did try to answer, but maybe not as clear as I could have been,
not
so
at
my
all.
apologies. I think that's because we needed to understand about testing capacity and some of the wider, and it wasn't just one question we were answering. I think that's why we were able to go ahead with the discharge and get that completed from the Welsh Government perspective. But I was interested at that time around global testing of care homes, for example, so I was looking at potential wider protective features.
We're
And
going
I
to
think
move on to
by
that later.
putting things together, maybe that didn't help get the clarity as quickly as we should have done.
And when do you say you had the capacity to test all patients on discharge? Can you recall when that was?
Well, in terms of capacity to begin to do the testing, that was really from the May 15-16 period into June.
So I'm talking just about discharge at the moment.
Discharge.
Hospital
No,
discharge.
that we were able to do that then.
Okay.
We were.
Now, I want to move on now to ask about the move to testing, asymptomatic testing within care homes, if I may. Now, initially, obviously, there was the Easter 6 study that was conducted by Public Health England that raised and concluded that symptoms were poorly predictive of infection and therefore a poor trigger for control measures. And that's plainly speaking to potential asymptomatic infection there. Now, when were you first made aware of that study? Do you know?
It would have been, quite quickly because the team were picking up on things. So as soon as that started circulating in SAID's papers, etc., I was alert to that.
Thank you. And it was published on the 19th of April. So it
Yeah, that would feel about right.
Indeed. And then if I can just ask you in relation to this, it appears that the decision within the Welsh Government to test all patients, asymptomatic residents and staff, was prompted by the UK Government's announcement. Is that right?
I think, yeah, there was a number of times where UK Government, based upon SAGE, had moved and we would follow on that advice.
And so that announcement from the UK Government came out on the 28th of April, if that assists.
Yeah.
So that was to apply to all residents and staff would be able to get access to a test regardless of whether they had symptoms. And it was the 2nd of May in Wales that there was an announcement that there would be further testing in care homes, but at that point it was symptomatic individuals and that they would be combined with isolation pending results, and then testing effectively where there was somebody with symptoms of COVID, but also the care home had in excess of 50 beds. So the larger care homes. Do you recall that?
Yes, I do recall that very clearly.
So at that stage, there's not a rollout to all homes of asymptomatic testing. Why was there a delay?
Well, I wouldn't say there was a delay. The decision at the time, based on the medical advice and the science, was still indicating that we did not need to move to testing of all asymptomatic. And that is, again, I've mentioned learning points. The question going forward is, at what point should you begin to test for asymptomatic? You may be coming on to this, but we then see the science change in certainly that second week in May, where we have, I think on the 12th of May, around that date, a SAGE meeting and advice coming through, which clearly indicates in the language I think was used at the time, the value in testing asymptomatic. And therefore, the policy changed in Wales around that mid-May point, around the 14th, 15th of May.
What I'm really asking about is the fact that obviously the UK government nonetheless announced this on the 28th of April.
But their policy, you recall, I'm sure you will.
I was going to say, it evolved effectively, but what we saw from the Welsh Government was the 2nd of May, that expansion, but it was not until the 16th of May that the Welsh Government then implemented and announced all testing for asymptomatic care residents.
But I could stand corrected on this, but in the meeting of the 30th of April, my understanding was that the announcement on the 28th of April from the UK Government wasn't the position that was being held. So that all asymptomatics, my understanding was that that was not the position of the UK government on the 30th.
It, as I say, evolved over the next few days, but it was certainly the case that the UK implemented it before Wales, and that's why I'm asking about the delay.
Well, you know, and I've answered that question, I believe, I hope I have, and I'll certainly happy to go back over it, but it was where the science and advice change around the 12th of May that was critical for the Welsh change in the guidance around the testing.
Now, I want to just turn now, if I may, to experiences of care homes where they had patients discharged to them who did indeed demonstrate symptoms of COVID and later were to test positive for COVID. If I could just bring up, please, for the Every Story Matters record, that's 587564, it's page 65. Just to ask you about the experiences, as I say, of some care homes. So here we can say, see, if I can go down to, I'll just choose the one midway down actually. The hospital would say they didn't have it, so that's a reference to an individual being discharged, being told that they did not have COVID. Then when they literally come through the door to us and we would test them, and they would be positive for COVID. I believe hospitals couldn't manage the amount of patients they had, so it's easier for them just to let the residents go back to their care homes and leave carers and nurses to deal with them. Now, obviously, putting aside the issue that a test on one day can give a different result, these are themes that recur in relation to discharge of patients. That also perhaps fed into those concerns that the overriding concerns of the Welsh Government were the preventing the collapse of the NHS, and very much secondary, if not for much further down the list, was the care sector. What do you say in relation to that?
Yeah, well, I think some of the experiences were experiences that we would have not have wanted to have seen happen. And, you know, I take the care home experience here. Certainly from my role and my directorate, you know, I would say there were lots of illustrations where we were actively supporting social care, engaging with social care sector, and also advising Welsh Government, whether that was the CMO or other parts of Welsh Government, in relation to the importance of, you know, ensuring that the social care sector was well supported at this time. And I think, you know, there is lots of evidence of the role of my directorate in that position.
And then also, just if I may, on the testing then that did take place in care homes of people with symptoms.
Yes.
So before asymptomatic testing is rolled out, and testing is limited to just those individuals with symptoms. And we've heard previously from Mrs. Hoff, a care home owner and nurse, that they would request tests, but then those tests would arrive late, often sadly after their resident had died. Were you aware of those issues?
I was certainly, and you know, in that scenario, that was quite a dreadful scenario. So I think that has impact for us all. I was aware of many illustrations during the pandemic of times where things were difficult, challenging, and around sometimes test results coming back as well. So although there was a high rate of test results coming back, it wasn't 100%. And so those issues were real and challenges that we were facing.
And what, if anything, did the Welsh Government do in response to that? Was there an attempt to expedite tests and things?
Oh yes,
of that nature?
very much so. Very active indeed.
And we've also heard that when those tests were received, they were unable then to be repurposed for anyone else. Now, this was at a point where there was said to be scarcity of testing, so every single test mattered or counted. Why was that the policy?
Well, testing wasn't my policy area, I'm afraid. I know there'll be others who are better placed to give you a good response on that.
Of course, thank you. If I can move, I appreciate it's not your policy area. You cover it to quite some degree within your statement, and I appreciate the reasons why. But what you do say in relation to testing specifically, yes, and this is where you are involved, is that, and this is more broadly across the sector, In the early stages, it was difficult to be clear about who was making what decisions for testing and where, and therefore difficult to ensure social care testing policy was optimal. So in that respect, why was there that lack of clarity of who was responsible for testing policy? Because as we see, those problems appear to persist nearly all the way throughout 2020.
I think in the early stages, my assessment is that, this was new. It was a different type of challenge. So that between ourselves, Public Health Wales and others, it was difficult to know who was leading. From conversations I had with the Director General, I know that he took steps then. For example, he appointed Joanne Daniels to lead. And from that point onwards, I think I've seen a considerable change in terms of understanding and grip as well.
Can we talk about a specific example, please? And that's in relation to domiciliary carers.
Yes.
And it's an example that you provide. And what we can see is that in Wales, the weekly testing of all care home staff was rolled out on the 15th of June 2020. Domiciliary carers were not a part of that rollout or that programme, is that right?
That is indeed correct.
And you certainly, within your directorate, had considered their inclusion. Had you considered their inclusion prior to the rollout, or was it something that took place afterwards?
No, we were considering domiciliary care workers very early on. I've got, clear illustrations where I and others were raising issues around domiciliary care early in the pandemic.
Indeed, in a paper, a written case in support of testing domiciliary carers was provided to the government testing cell on the 10th of July of 2020 from your directorate.
Yes.
But it was not considered. Do you know why it was not considered?
I do not know why it wasn't considered, but I know it was brought back to their attention.
And you continued, you say in your statement to press, and it was resubmitted a couple of weeks later on the 28th of July. And in relation to that, if I can just set it out, what was the pressing rationale in your view as to why domiciliary carers ought to be tested at that point?
So my rationale with this, obviously I'm not a doctor, I'm not a scientist, but my rationale was that, and there's this long answer and a short answer. I'll go for the short answer and see if that helps, is that, domiciliary care workers are mobile between different dwellings. They're going into different people's homes, coming into contact with lots of people. And my issue was also about protecting them. Of course it was. But it was also recognizing that they work with very vulnerable people. And it was about protecting those vulnerable people as well. So I felt that a testing regime, and that's why personally, when one of the big moments in the pandemic for me was the introduction of lateral flow devices. And it was at that point that domiciliary care workers were part of that testing regime.
Indeed, and that's not, however, is it, until the 23rd of November of 2020,
it's
so it's quite late then.
Yes.
You'd submitted, as I say, the initial paper on the 10th of July, resubmitted it on the 28th of July. You set out the rationale as you've described, effectively, if you've summarised now. It also noted that there was a clear disparity between that testing available within social care settings, care homes and the like, and that was not available for domiciliary carers. And within that advice, it set out that in regards to that disparity, there was no clear rationale for that disparity. Was that your view?
Can you just repeat that again?
Of course, I'm sorry. I probably confused you. Sorry, what I was saying was, within your written case,
yes,
it set out that there was no clear rationale as to why there was a disparity between testing of all care home staff that was rolled out and domiciliary carers. So it's that disparity, and there being no proper justification for it. Was that your view at the time?
Well, I would actually say no. My view was that domiciliary care workers should be tested for the reasons that I've set out. But the decision back was based upon the medical scientific advice. There was all sorts of analysis around the percentage of domiciliary care workers versus the population of people infected. I think not seeing them as entering closed settings, but there will be others who will be better placed on the side of those that were offering that advice. My constructive and purposeful challenge was that I felt that domiciliary care workers, and indeed one of my learning points is that I would like to see in the future domiciliary care workers seen in the same capacity as we would view the importance of testing care home workers.
You've referred to scientific advice in relation
Yep.
to the testing of domiciliary carers. Do you know if there was sufficient testing capacity at that time?
Well, I wouldn't be able to answer that question at that time. Testing was improving the scale and scope. So, again, others would be better to say, yes, we had capacity, no, we didn't. I felt by that period we probably had more capacity than we certainly had at the earlier stages. I don't believe it was just a capacity decision. However, I think it was the decision from technical advisory group and others was that they did not need to be tested.
Okay. Now, just dealing with one of the other rationales that was put forward, or the other arguments for testing, you had evidence within your directorate of domiciliary care packages being refused by users because of their anxiety over potential transmission by those care workers entering their homes. Is that right?
Yes.
And do you accept that that in turn could potentially pose risks to those disabled people in terms of having their needs met if their anxiety was overriding the actual provision of that care?
Indeed.
Did you or your department within the directorate make any further inquiries or take any action to seek to reassure those people that were in receipt of domiciliary care?
That would be the responsibility of the local government, those that are providing the delivery and the care.
Was any guidance provided to or information provided to local government?
I don't believe we provided any information, nor do I think we were asked for any information.
Now, obviously, care homes had attracted a significant amount of attention, and indeed those and staff and ingress routes and those sorts of policies. But was this an example of domiciliary care being a bit of a blind spot? The fact that it was not being prioritised in the same way?
No, I don't think it was a blind spot, because then I would, I'd say obviously we promoted and had the discussion as we've just described around testing, but we were providing PPE and other support. So whilst I've answered the question in relation to testing and individuals, it was quite clear that we were supporting dom care workers as we would do the other workforce, especially around personal protective equipment.
And you've explained that obviously all of these people that are being cared for have vulnerabilities in relation to COVID and potential risks in terms of infection. What about unpaid carers? Were they being considered actively during this time? Because they are obviously also providing care to individuals who may be at greater risk of infection or serious consequences of infection.
Yeah, I mean, unpaid carers during the pandemic were absolutely tremendous, but also had impacts. They were isolated. They had other hardships, financial. But we were very mindful throughout the pandemic around support to unpaid carers. Unpaid carers were able to access PPE. There was criteria that was developed to access PPE. And also there was other supports that we put in place. Through hardship funding, working with some of our key partners to get respite services and support in other ways.
But if I
so they weren't for me. They weren't. I think, what was your word? It was
I'm not sure.
Unseen
being considered.
They were definitely being considered.
But specifically in relation to testing is really was my question. So were they, during this period, being actively considered in relation to potential rollout of routine testing in the same way that you were looking at domiciliary carers?
There were lots of groups that we were looking at in terms of when we should be able to test. And I think that was, again, when I mentioned that kind of light bulb moment, which, for me was so important. I think the development of the lateral flow devices then opened up the ability to do much more around supporting unpaid carers and others around testing.
Indeed, but that was to the general population in November. What I want to know is whether, was there a specific time at which unpaid carers were specifically considered for potential routine testing?
Well, I wasn't involved in all of the testing decisions. As I've mentioned, I didn't lead on testing, but I know that my policy officials were looking at a number of groups around testing, and I know that they were also thoughtful and mindful to raising issues around where we support and how we support unpaid carers.
But am I right that you cannot actually assist us on whether or not
I
unpaid
can't.
carers were
Others
being
will be
considered?
better placed on that, I'm afraid. My apologies.
And just to complete the chronology, it was in November, effectively, that because of your concerns, you say in your statement, over testing and coordination of testing and responsibility for testing, and those issues with papers not being considered and so on, that you had discussions more broadly with Public Health Wales, the Chief Medical Officer, the Welsh Government Testing Senior Responsible Officer, to try to seek a more coordinated group, and that resulted in the Social Care Testing Infection Prevent and Control Group in November of 2020.
Yes, I set that up.
Indeed.
Yes.
And you chaired it initially.
Yes, I did.
Thank you. Now, if I may turn to a new topic, and that it engages the role of Care Inspectorate Wales
Okay.
and the cessation of inspections within Wales. Now, within your statement, you explain that you were supportive of Care Inspectorate Wales's decision to suspend those routine inspections. And we've heard evidence from Care Inspectorate Wales as to why that was, but that you were reassured that safeguarding issues and other concerns would continue to be investigated. Now, looking back now on that decision and just taking your perspective, putting aside those of Care Inspectorate Wales, do you still believe it was the right approach for Care Inspectorate Wales to suspend those inspections?
I mean, obviously it wasn't a decision for me to make, but I still do believe that was a balanced decision that Care Inspectorate Wales made.
And did you or anyone else consult care home residents and their families about the suspension of those inspections?
That would have been
for Care
yes,
Inspectorate
it would have
Wales.
been. It would have been.
Now, a number of core participants, including COVID bereaved families for Justice Cymru, in their corporate statement have raised concerns about the suspension and general reduction of those inspections over the course of the pandemic. They're concerned that without regulatory oversight, it's difficult to know whether their loved ones were provided with proper care or there were any safeguarding concerns. How were you assured about that care provided in Wales in the absence of inspections as the Chief Social Worker and with all of the responsibilities that your role involves?
Yes, I think it's a great question, a great challenge. I think at the time, we look back and we know that care homes were isolated. But I think for me, what reassured me during that period was that, Care Inspectorate Wales weren't operating away from the sector. They were operating to the sector. So they had their check-in weekly calls. There was lots of communication. I was regularly in touch with Care Forum Wales, for example. There were lots of contact points about, standards of care. Was very active around promoting, visiting, balancing the rights to protect individuals, but the rights for people to see their loved ones. So I think our contact around care homes and the environment was very lively, very active with lots of partners. Obviously, I wouldn't be cited on individual care homes, but I know that where issues were raised, they were acted upon by Care Inspectorate Wales.
Thank you. Now, if I may, I'm going to move now to visiting restrictions in care homes. That is an area that your department, indeed you were very heavily engaged in during the pandemic in terms of promulgating guidance. And that first guidance on visiting in care homes was issued on the 23rd of March of 2020. If I could just bring that up, please. It's 336-332. Thank you. And here we see a letter going out to the providers dealing with guidance for visits. And what we see within here are effectively that visits are going to be limited to essential visits only, I'm paraphrasing, but that's essentially what it amounts to. That non-essential providers or contractors such as hairdressers, builders, whoever it may be, could no longer enter. That also applied to professional visitors unless it was essential, doctors and the like, healthcare professionals. Within the guidance, you say that you recognise the importance of relationships with family and friends and emotional well-being, and cannot reinforce strongly enough the crucial roles visitors can now take in protecting their family and friends by not visiting while continuing to support emotional well-being in alternative ways. You explain that this is going to be individual case-by-case basis, decisions to be taken by care home managers. Those are who the request should go to. So that's where the decision-making is taking place from your perspective. Is that right?
Yes.
At the very local level within the individual care home.
Yes.
You appreciated that there were going to need to be sensitive discussions in regard to end-of-life care for those residents, and that you'd hope that these restrictions would be in place and undertaken for the shortest possible period. At that point in time, were you expecting these restrictions to be a matter of weeks as opposed to prolonging over more than a year, 2 years?
Certainly at that stage, I wouldn't have foresaw that we would have 14 versions of guidance for visiting. So, absolutely did not foresee it being over that length of time. But also, even at the very beginning, was aware of the importance of visits and context and well-being. Hence, it wasn't a blanket approach. And also, I know that we supported a number of, tablets and other digital material to try to help care homes and loved ones keep in touch.
And just dealing with the guidance that was promulgated, as you say, a number of iterations.
Yes.
Each iteration of that guidance was developed within the parameters of what the national restrictions were, or the local restrictions were at any given time. Is that right?
Yes, it is right, but there were points, for example, the fire break that took place, I think end October, beginning of November. A reasonable excuse was a visit to a care home where that was deemed to be appropriate.
Indeed. And I'm going to move to some of the issues that you had in the fire break in due course, but I'm just concentrating, if I may, at the beginning of that guidance and how it developed. So on the 27th of May, you met with the Older Persons Commissioner, Helena Herkotz, who we heard from yesterday, and you agreed at that point that guidance should be co-produced in conjunction with the sector. Obviously, that's going to be more time-consuming. Why did you consider that to be important?
I think, firstly, I think the Older People's Commissioner played a very important role during the pandemic. I was very grateful for advice and challenge. I felt that at that stage it was really important, given the length of time that had already occurred between the beginning of that lockdown, the 23rd of March restrictions on visiting. And, this is where good working across partner organisations, we were able to work, Care Inspectorate Wales, held a group. A group itself doesn't achieve everything, but within that group, critical stakeholders were able to really bring alive and make sure that we could balance the rights of individuals.
Thank you. Now, I'm just going to deal with some of those iterations. So, and as I say, they align broadly with what restrictions may have been in the wider community. So the 1st of June, when the stay-at-home message was changed in Wales to one of stay local, at that point, there were permitted outdoor visits, and you sent your guidance at that stage, encouraged the facilitation of those outdoor visits. That was then followed up again in various iterations. Version 3 of the guidance came in on the 28th of August. That saw a move to permitting indoor visits, and that again reflected a change in national restrictions. So they're following the national restrictions broadly. Is that right?
Yes, broadly.
So what we've got there is the availability to meet indoors. But by this stage, you'd had fairly significant correspondence more broadly from both individuals who were subject to these restrictions and their loved ones, but also the Older People's Commissioner with significant concerns being raised. And what was your view at that stage? So this is
Yes.
in August moving into the September.
So August moving into September, those that took the time to write was very grateful to them sharing their stories and position, and I thank them for that. I know it was very painful for them, but we were able then to, I think, advocate for that balance, recognising the rights of individuals to see their loved ones and to balance risks. So we talk about dynamic risk assessments. And certainly for me, we were moving then to, indoor visits, and without leading on too far, because you may be going there on future questions, we did a range of actions that supported and enabled visiting to take place.
I'm just going to ask you, if I may, then, about the September local restrictions before we pause for a break. And in relation to those, the local restrictions were introduced in various areas within Wales in response to rising infection rates. A number of those of local authorities decided, however, to cease all visits, so put a blanket ban effectively on visiting, at a point when, in terms of the more broader restrictions, outdoor visits were still permitted. So we see that in Caerphilly, for example. And those were, you explained, decisions taken typically in collaboration with the incident management teams from Public Health Wales. But when you were aware of those effective blanket bans being put into place, what did you do, if anything?
Well, I took action. Both myself and the Chief Inspector, Care Inspector at Wales, wrote out to all local authorities across Wales. We were very clear in our expectation and supporting. We spoke with Welsh ministers and we spoke with key stakeholders.
And indeed, slightly later in September, it became clear that at least 2 of those local authorities had imposed bans on visits without the incident management team input, or any input at all, actually, from Public Health Wales. And in those situations, did you write to those local authorities as well?
We wrote to all authorities in Wales and we were very clear. I think where you've got the decision made by the incident management teams, I think we can understand that restrictions are because of the local prevalence, so we can understand the decisions being made. What we would not want is those decisions to be made in isolation, nor for any length of time that is unduly.
And you referred to it briefly earlier, but at that stage, in addition to the more broad ability to visit outside or to see people outside in terms of the broader regulations, under the actual coronavirus regulations, visits to care home residents were an acceptable reason to nonetheless visit, weren't they?
Yes.
It was an exceptional reason to travel. You could travel under compassionate grounds that included visiting end of life, or where those absences could have a significant impact upon those residents.
Yes.
And notwithstanding that being effectively within the regulations, we still saw, or you still saw within Wales in some areas, those blanket bans.
Well, you certainly saw decisions being made that were contrary to the guidance at that time. Some of that I understand, not justifying, but understand that individuals were, cautious, anxious, worried. But it's quite clear that we give good advice based upon what well discussed with both, the Public Health Wales colleagues and other partners. We give good advice to try to support and enable visiting to take place in Wales.
Thank you. And in terms of the guidance that you wrote out, certainly you were informed that the Older People's Commissioner was content with that guidance and reported back to you that there had been an increase then in facilitation of those, at least the outdoor visits, and indeed in some cases those more exceptional visits.
Yes.
Thank you. My lady, if now's a convenient moment for a break.
Thank you very much indeed. I shall return at 20 past.
Thank you. My lady, if I may now pick up, please, on where we left off on visiting restrictions. We had reached the point of the imposition of local restrictions within Wales and the impact those had on visiting restrictions. Yes. We were looking at effectively the period up until September of 2020. I now want to turn, if I may, to the fire break, because you say there were significant concerns and they became fairly acute in relation to visiting restrictions when the fire break was imposed in Wales. Can you explain why that was and how it became particularly acute?
Yeah, so, thank you. The fire break was described as a circuit breaker to try and interrupt the spread of COVID. We certainly negotiated that an exception was to have visits to care homes, but I acknowledge that was, whilst permissible, was during that period more challenging because of the spread of the virus at that point. But it wasn't, again, as I mentioned earlier, it wasn't restricted, but was on an assessment between the provider of the care home and the families themselves.
And in practice, what did you see start to emerge? Did you see the same sorts of issues that had taken place during the imposition of local restrictions in September re-emerge during that fire break period in October through to November?
I think it was probably actually a quieter period for those issues because, I think there was an understanding across Wales of the need to try and interrupt the spread of the virus. So during those, what I would describe as a 3-week period, I think where possible, visits continued, but obviously some visits wouldn't have taken place during that period.
Thank you. Now, throughout this period, various other avenues were explored. You've touched upon some of those earlier in relation to the use of devices, obviously.
Yes.
We've heard a lot of evidence in relation to the use of technology. Also, the use of pods. Yes. There was a pilot in relation to pods that was rolled out. And then also pilot lateral LFT testing of visitors as well that was rolled out prior to the Christmas period. And you described that as being particularly important because of the value of Christmas, essentially, to those residents and their loved ones.
Yeah, I mean, it's interesting. I love Christmas. I'm a Christmas person. Not that my lady needs to be aware of that, but recognise that the pods especially were a longer term investment by government, and that was really recognising the need and the well-being needs of individuals to see their loved ones. So certainly my colleagues in the civil service worked really, really hard to try and support, and I was really pleased that ministers financially supported both purchasing pods by us, but also I think it was something like 55 were financed in addition to that as well. And as you mentioned, using lateral flow devices. Later into the spring period, we support volunteers as well to support visiting and really good work across the sector.
Now, I want to turn, if I may, to the period surrounding Christmas and going into January. Yeah. So we're effectively infections are rising, notwithstanding the fire break. Yeah. It's essentially coming towards the peak of the second wave. And alert levels were then put in place, essentially, for social care services as well. And in relation to those alert levels, the guidance aligned to those alert levels. And that was the first sector-specific plan you described within the UK, seeking to provide clarity over the changes in visiting guidance. And to be clear, and just to explain, that coronavirus control plan alert level document in terms of Wales for social care services links social care testing, infection prevention and control arrangements. And so it was clarity in two respects. Firstly, over the testing requirements, and secondly, over the IPC requirements that would be put in place, including visiting.
Yes, it was.
Okay. Now, at this point, visits continued to be allowed in exceptional circumstances. They were not limited to end-of-life care. But notwithstanding that, there was some initial confusion and further reluctance on the part of some care homes to allow visits at all. And we've heard some evidence in relation to that, with individuals not being able to see their family members throughout that period. Why? Did you understand why these care homes were reluctant at that point to allow visitors in, notwithstanding the guidance?
Yes, no, thank you. I do understand why they were worried, concerned. I think it was very natural to be worried, concerned. I think that the second wave is probably the most painful wave for a lot of us, because the first time we'd gone through, we had learned so much and put in so many different features to support. But still, as community transmission rose, so did the prevalence within care homes. And I think that's why it was at that stage that there was a nervousness. What we continued to do was try to support and enable and maintain that openness to supporting visiting.
In terms of the use of exceptional circumstances, or the term which was contained within it, which was absolutely essential in terms of permitting visits, do you think that contributed to some of that perceived lack of flexibility with care?
I actually thought the plan was really helpful. I think the alert levels were really helpful. And I think as we move into 21 and levels change within Wales, I think it was also clearer in terms of being able to, step down the alert levels as well and open up. So I think actually I found it a helpful plan, especially as we move into 2021.
In terms of looking to the future, are there any particular recommendations that you've or lessons that you've learned from that process, including the alert levels document, the framework, that you think would be helpful in a future pandemic, and can work on those be done now?
Yes, I think definitely, yes, I would agree.
Now, I'm not going to go through the subsequent iterations, but suffice to say there were a number all the way through, essentially, all the way through, including Omicron, and then as coming out of Omicron and the learning to live with COVID strategies, or COVID zero, within Wales. Just in terms of care homes and their capacity to manage visits, to what extent were practical constraints a real consideration within Wales? So, for example, the layout of the home, whether they have outdoor grounds to accommodate outdoor visits, all of those sorts of issues.
Yes, so all of those issues were definitely being taken into account. And, because Wales has a different profile around care home owners, a lot of owners with one or two homes. We were then having to accommodate workaround support around different physical environments, but they were offered advice, assistance, and as we've mentioned, visiting pods and other things that we thought would be good enablers to creating and maintaining those relationships between the loved ones.
If I can just pick up on visiting pods, which were obviously a very good innovation for the sector. We've also heard that some care homes were creating their own visitor pods earlier, effectively, in the pandemic. Obviously, the pilot was rolled out in November of 2021. Is there some learning to be done there, and could that have been effectively put into place much earlier? And the reason I ask that is not least because of the particular vulnerabilities of many of those in the care home sector in terms of cold and being outside and all of those sorts of issues.
Of course, I wasn't quite sure I got the date right there. So just to say, because my understanding is that we did the care home pods in November 20, leading up to that.
I meant November 20.
Yeah, no, I'm sure. I wasn't sure. I heard my hearing sometimes. I wasn't sure I heard the date correctly. And I think, again, all of the learning will be, hopefully we don't have to face this anytime soon, please. I hope so. But if we did, we've learned that if we can do these things earlier, then we can enable. So there's no doubt that that was a good thing to do. And, something that, again, as I mentioned, as lessons learned, you can certainly look at what worked well and can you do that earlier in the cycle. And they were much more protective and supportive, and, arrangements for cleaning and all the things that go with that were well in place.
And just to deal with the timing of that being November 2021, were pods or anything of that nature, accommodations to assist care homes in providing visits, considered at a much earlier stage, or was it something that really came about in the autumn to winter period?
In truth, it really come about at that period. I did think we were being innovative and supportive.
Now, if I may, I'm going to turn to the Care Homes Action Plan.
Yes.
There will be some further questions upon this in due course, but if I could just deal with it in this way. It was published on the 30th of July of 2020.
Yes.
The aim of the Care Homes Action Plan was to directly address the challenges that were being faced by those care homes during the pandemic. So this is at a point where, to place it in context for you, the restrictions are being relaxed coming out of wave 1 into the summer period. You explained that was a product of your directorate and an aim to learn from the first wave to prepare for a further wave. Now, the Older People's Commissioner for Wales, Helena Herclots, had called for an action plan in a letter dated the 14th of April 2020. Were you aware of that?
Yes, I was.
And indeed, she had sent you an email also, hadn't she, following up on that, explaining that she that she wanted an action plan like that announced in England. What prompted that Care Homes Action Plan?
Well, I think at the time where the Older People's Commissioner helpfully raised that, the minister, the deputy minister, was able to consider. We were still very much in a position where our staffing capacity wasn't really in a position where we could have said, right, we'll do an action plan today, because actually what we were doing was largely working, flat out on the actions that ended up being the actions within the action plan. So it wasn't that work wasn't being done, because it was being done. But once we hit that summer period, the deputy minister was really keen that we develop an action plan, set that up from us. It was very clear in June that she wanted it, and she was very much about people's rights and promoting and supporting. So that was at the stage then where the minister was keen for the action plan to be developed.
Agreed. And if I can just draw up on the screen, please, 253707. This is the update provided to ministers on the summary of the progress that's been made against the action plan. So looking at what was achievable and what were the next steps. And I just want to deal with, if I may, the first one, which is the development of a clinical contingency template to provide further advice and support for individual care homes. And so that's really dealing with IPC management, how to manage individuals with infections within the home. As it says here, it will include environmental staff management, minimising staff movement, personal protective equipment, PPE, testing, considering their own resident group, staff group, environmental layout and service delivery. You may have already touched upon the lack of capacity in your team, and that may be the reason, but why was this only taking place now, effectively, with a target date of October 2020?
Well, I think IPC advice was being given to care homes much earlier than that date. But what this was about was developing what I'll term as a toolkit that could be used with further training and support. That toolkit was produced. Subsequently, a lot of work across Social Care Wales, Public Health Wales, and that work's been progressive to this day. We now have a workbook and training materials that I've endorsed alongside the Chief Nursing Officer. But it would be fair to say that work was taking place, before this, but it was about the toolkit, which we did produce.
Thank you. And just dealing with that toolkit that was produced, it became a checklist.
Yes.
Is that right?
Yeah, I know.
And there was a further update following on from this update in October in December. And at that point, that has still not actually been completed, albeit that an initial checklist had been developed but not rolled out. And it was later confirmed that the checklist was then sent in January to be circulated onwards. So we're talking about a fairly significant period in getting that checklist together. Now, you've explained what the work that was being undertaken, but would you agree it would have been obviously a very useful tool, you've described it as a toolkit, for those care home providers and individuals concerned with the provision of care to have had earlier?
Absolutely, but important to bear in mind that environmental health officers were going in to homes who had infection control issues twice a week. There were a whole range of other measures alongside that, but I do believe it was a very important step forward, and hence why I personally endorsed, I'll call it the workbook. I know it's got a proper title, but I've endorsed that, and it's really taken, it's taken steps further forward from 2020.
Indeed, and your directorate would not have produced it had it not been considered to be an important, valuable tool for that sector to use.
No, and
That's why I
indeed
asked
working
the
with
question.
Public Health Wales and partners who have been instrumental in this.
Now, if I can also deal with the rapid review that was taking place alongside the development of the action plan. That was a review by Professor John Bolton. It's an independent review to look at the experiences of care homes during the pandemic. Now, there were concerns raised by Helena Hercots, the Elder People's Commissioner, that the review would not sufficiently engage with what had gone wrong and instead would overly focus on what had gone right in the pandemic. What do you say about that?
Well, to be fair, it's really important that the Older People's Commissioner raises concerns and issues. That is good for us because we're able to consider and respond. You will have a copy of the material that was sent out at the time. That clearly talks about weaknesses, gaps, and I think Professor Bolton did a really good job at speaking directly to regions, gathering what worked well, but gathering what needed to be improved, and come up with a very clear set of recommendations and advice, which I found very useful, and also the team found very helpful because we were able to incorporate that into the Care Action Plan work as well.
Thank you. That deals with my next question, which was how was it used? If I may then turn to one aspect that was identified within the action plan, and that's the one of staff movement and the risk of transmission. So staff movement, we've heard, is a significant challenge. It's an ingress route for infection across the care sector in that respect. And that's been a long-standing understanding within the adult social care sector in relation to other infectious diseases, hasn't it? So this understandably was a significant concern for those in receipt of care, and we've touched upon those in receipt of domiciliary care and the concerns and anxiety that they expressed at the time. If I could ask, please, for the witness statement of Catherine Griffiths to be pulled up on the screen. Okay. Page 9, please, paragraph 30. Thank you. Here, it sets out that a significant concern of COVID-bereaved families for Justice Kimmery was the risk of staff spreading the virus between homes. The use of agency staff was commonplace. Firstly, if I can stop there, that's correct also, isn't it, of the situation in Wales? The use of agency staff?
Yes, yes.
This inevitably led many staff to move between homes or even region to region. And just again pausing there was a point, wasn't there, where individuals were moving from region to region because of workforce shortages within Wales?
There was certainly, at a critical point in the pandemic where we were actively encouraging, allocation of workers to single homes only. But there was no doubt, and it's something that is about workforce planning for the future, for the now. We clearly, there were times where the sector could not prohibit the use of workers across because of the pressures that they were under. And that is a very sad thing to say, but I know a lot of work was done to try and keep it to the absolute minimum.
Indeed, and if we continue on, we see that the concern is that the continuous source of movement likely contributed to the spread of virus between homes. And we've seen that certainly is the findings of the Vivaldi study, and we've heard from Professor Shellcross that it's one of the ingress routes. And here it's a reference to your evidence, your witness statement, where you accept that despite the risk posed, as you said, the pressure on the system put the social care sector into a position in which they could not prevent it. And so that was particularly frustrating to their members, who found that many care homes were also still accepting patient discharges from hospital at the same time. So these were concerns of those residents and their loved ones in relation to restriction. But essentially, there was just simply not enough capacity within the workforce to enable a policy to limit staff to one home only.
Certainly at the early stage of the pandemic, from the feedback that I had from the sector was that was not possible. However, I did write out in August I think it's August 17th, really clearly setting out the expectation around, allocation of agency worker to single homes. I felt that was doable then because the rate, if I remember correctly, at that stage of allocation to individual homes was something like 90% of agency workers in Wales. So that was really pushing home that message about risk and how to manage risk.
Certainly at the outset, you explained that had you instituted such a policy, barring the transfer, the working between different homes, then you would not have been able to implement the hospital discharge policy, for example, at all, or other policies, including and down to just delivering basic levels of care.
It would have had impacts across those systems, as you say, a whole system thinking, of course. But importantly, it would have an impact in the quality of care within those care homes themselves. And that was what the advice was coming from, care providers to me at that stage.
And looking to any future pandemic specifically, is there anything that you consider that could be done to resolve that position?
Well, I think yes, I do. I think the whole workforce planning and the whole workforce investment is absolutely critical. There are challenges that the sector faces that I think we can address, but perhaps I'll come on to some of those, I'm sure, during the discussion. Thank you.
And related to that were issues in relation to staff absences.
Yeah.
And again, if I can call up the same witness statement, but paragraph 33, it picks up on your earlier comments about the sector being fragile, but it explains that the absences resulted in a dramatic drop in quality of care afforded to their loved ones. Certainly we've seen some evidence of that from ADAS and organisations with limitations to what they could achieve. And then it continues to go on through that in Denbighshire saw 15% of its local authority social services workforce take time away from work due to COVID-19. Staff absence varied between 10 to 35% through the relevant period, and that's where it resulted in the need for staffing, mutual aid, or the introduction of agency staff. So again, increasing the infection rates. And you've dealt with the issues of workforce capacity. Just picking up on the ability to self-isolate, we've heard about financial concerns of individuals within the sector. Is that something you've given thought to?
Yes, there was concern, and I know we were able to support through the enhancement to statutory sick pay, and I know that we were able to support with particular payments, recognition rewards to workforce who were during the pandemic working above and beyond any expectations at what they were doing. It was absolutely fantastic.
Thank you. And if I can turn then to the issues of infection prevention, control and PPE.
Yes.
The initial advice was that PPE was only required when dealing with those COVID positive cases. In hindsight, do you think that was the correct advice?
I think I accept that as the advice that was at the time. I accept that as the advice.
I just want to again touch upon, if I may, that certainly the possibility of asymptomatic transmission was discussed within the initial Health and Social Services Group COVID-19 Planning and Response Group as early as the 20th of February. Given that, and the potential for asymptomatic transmission, why were social care providers not advised to wear PPE when caring for all residents discharged from hospitals as a precautionary measure?
Yeah, no, it's a very, very fair question. My response is that the continuing advice to us in terms of the medical advice, the scientific advice, as you will have seen from my statement, continues to recognise the risk differently between symptomatic and asymptomatic.
Was that based on scientific advice, or was it more to do with the lack of adequate PPE at the time?
No, certainly my understanding was throughout that period was based upon the scientific advice rather than the amount of PPE. In fact, I think the efforts around supplying PPE, were gone to a great lengths.
Now, the inquiry has heard significant and received significant evidence of PPE shortages in care homes beyond March 2020, beyond the initial period, but for quite some time. So, for example, in April 2020, Care Forum Wales sent a letter to Mark Drakeford saying barely receiving any sufficient PPE. Chris Llewellyn of the Welsh Local Government Association similarly refers to shortages. Care home managers have provided evidence that they were locking PPE away, they were stockpiling it. We've heard some evidence that social care workers were reduced to using one mask per shift as a consequence. Equally, care homes becoming reliant on people in the community making masks and gowns. And we've heard some further evidence this morning about difficulties in relation to what the NHS central supply chain was able to provide at that time when the government took it over. Do you accept that there remained widespread PPE shortages in care homes after the Welsh Government assumed responsibility on the 19th of March of 2020?
I think it's a challenging question. Do I accept? And thank you for the question, by the way. I think what I would say in response to that is, the duty to provide PPE. Government stepped into that space, so we stepped into a space that was occupied by local government and providers themselves. I think that was the right thing to do. And I think that was important. There was always enough PPE in the system. I had the very helpful military asked for them to do an assessment. They did the assessment between something like the 8th of April to the 18th, provided a report on the 21st. Logistics to making sure. And I think there were this was the first time in that chain, almost like a supply chain, if I can put it in that jargon term, which no one had done before. So people were sometimes stockpiling, and it took time, but PP was getting out. So I don't think there was a shortage, actually, overall of PPE. We run very close, however, and I was personally involved in conversations with, the shared services from the NHS, and we come very close on occasions, but with a matter of days in provision. But we never did run out, and we always got. And when directors of social services phoned me up late in the night saying, "I'm worried, I need PPE," I was able to phone the shared services, and they responded. We got into a different regulated beat with the sector, which did begin to ease those worries. But you're absolutely right. There were lots of challenges, but there was PPE, although recognising how close sometimes we come to the wire.
And presumably that PPE, where you say was sufficient, that was based on whatever guidance was in place at the time?
Yes, of course.
So whatever the guidance said, you're saying that was sufficient to accommodate that?
And we scaled up. And I think actually one of the learning points, forgive me for coming back in, but one of the learning points is how that national approach really benefited around PPE.
Thank you. I've just got one last question on this topic before moving on, if I may, and that is in terms of care homes and their ability, firstly, to isolate, and secondly, their ability to provide good ventilation. Just very shortly, what is your understanding of the provision within Wales?
Yeah, it's mixed provision. I've been in many care homes in Wales myself personally, and I know that providers are always working to have good ventilation, good standards. The Regulation Inspection of Social Care Act also has set higher standards than previous legislation as well.
Thank you. I now want to move to the final topic, if I may, that I have questions for you in relation to, and that is on DNA CPRs. Okay. So do not attempt cardiopulmonary resuscitation notices, please. And I understand that you and your team had limited involvement in the policy and guidance, but I just want to pick up on where your team did intersect over those issues. Now, Gillian Baranski, the Chief Inspector of Care Inspector at Wales, has provided evidence with regard to the inappropriate use of those notices. Certainly in one respect being used as a proxy for do not treat. And so, again, we've also heard evidence from Mrs. Hoff. She described the challenges she faced in terms of taking residents to hospital because they had those in place, and the care home providers' beliefs that those notices were resulting in automatic non-admittance to the hospital. I'll just call up, please, 500163. Go to pages 2 to 3. And this is being escalated to you, essentially, from Care Inspector at Wales. If I can go over the page, please, to page 3. These are concerns about a recent death at a care home. And they explain that paramedics were called out, but because that notice was in place, they were not admitted to a hospital. No palliative care package, and I'll move to that in a moment, was put in place. Controlled drugs were not issued. They passed away within 24 hours, and it deals with the nature of that, and obviously a far less dignified death than one would have hoped for, or would have been typically the case within the adult social care setting. And in regard to that, it explains that their residential services, they're being asked to operate outside of their registration by becoming nursing homes. So these are homes without those nursing capabilities, operating like a mini hospital ward. We know we all have to do our bit to help the NHS save lives, but they're asking too much in this instance. If we go back, please, to page 2. On page 1, sorry, of it. My apologies. And what we see here also is that it's being described as there being a race by GPs to put in place notices. Now, there were concerns about blanket DNA CPRs, and also that such notices were being put in place without any discussion with residents or their families, no engagement, in short. What did you do in response to those concerns? They're coming to you in your office.
Yeah, so although I don't have a remit, I wasn't responsible for the policy. You know, I was, like anyone would have been, deeply affected by the stories, the impact coming to me. Certainly, I raised it within the executive team that I'm a part of. I had discussions with colleagues who held responsibilities, and I think it was accepted by everyone that one case was one case too many. Actually, I think, and although, you know, looking back, I think there were a small number of examples. They were examples that we would not have wanted to see in Wales. So the chief nursing officer, the chief medical officer, you know, wrote out to the system clearly explaining, and I think that was again around the 17th of April.
Okay. And one aspect of this was also the use of the clinical frailty score. Now, Module 3 has heard evidence on that, and you provide various observations in your statement. But just to deal with that in conjunction with these notices, COVID-bereaved families for Justice expressed the view that many members felt they were being disproportionately affected. They were being neglected on the basis of age. They were being viewed as too old. And there were similar concerns expressed by disabled people, some of whom also had notices being put in place, including in circumstances where they plainly ought not to have been. Was there a lack of care and respect for older people or those more vulnerable to COVID?
I think the answer back to that one is that there was a few examples which we would not have wanted to see in Wales, but the approach certainly of the Welsh Government, both at a minister level and an official level, was one of wanting to support older people, support people with disabilities across the board, and a number of actions that we tried to take were in the supportive arena.
Thank you. And again, we saw from that email, and indeed from other evidence that the inquiry has received, that there were care homes without nursing. They did not have sufficient end-of-life care. They had a lack of medication stocked, oxygen being a particular issue. To what extent can anything be done about that to help that in terms of a future pandemic?
Yeah, well, I think it should happen, you know, it does happen day in, day out, and it must happen day in, day out. I mean, it must happen today. So anyone who has, you know, a palliative care, an end-of-life pathway, deserves dignity, respect, support, and there's a whole range of measures. So although I'm not the policy lead, I am familiar with the policy, and I can see within that, you know, if we adhere to that policy and that framework, then that is about working together with people and their loved ones around these decisions.
Thank you. And then my final question, please, in relation to the use of these notices. The CQC undertook a review. Obviously, that was in England. And then subsequent to that, several reviews have taken place of these practices in Wales. But each of these recent reviews concentrate on health boards and NHS trusts. There's been no review in relation to the situation within social care. Do you consider that something that is necessary?
I think I think the consideration of those in terms of, because these are clinical decisions, these are medical decisions. So I think starting from that basis is the right basis. But then, of course, you should always consider what the setting is for the individual. But within that individual should be caught within those policies.
And I've just been asked, if I may, very briefly, Mr. Heaney, to clarify one matter that goes back actually to questions that I was asking at the beginning. And that's in respect of the decision to test all patients on discharge on the 15th of April. You said at that point, both yourself and the CMO, Sir Atherton, wanted a change in policy. Can you please clarify who actually made that decision?
So good question. Thank you for asking. So on the 14th, there was a clear. I think it was a tactical advisory cell, advice, and often coming from SAGE, very clearly identifying the risks. England, as I mentioned earlier, changed the policy. There was a ministerial meeting held on relation to social care on the 15th.
There was.
Yeah, and in that meeting we discussed the testing and discharge from discharge. That's where Sir Frank Atherton, the Chief Medical Officer of Wales, was tasked with going away in terms of looking at that policy. And then there was a cabinet meeting held that just discussed it further on the 22nd of April. And I believe it was in those settings where that decision to move forward on the discharge testing was agreed.
Thank you very much. My lady, those are my questions.
Thank you very much, Ms Cecil. Mr Stanton, should be straight across the hearing room, Mr Heaney.
Thank you.
Thank you, my lady. My lady, Mr Heaney has already covered very fully two of the three permitted questions, so I just have one question.
Thank you.
Good afternoon, Mr Heaney.
Good afternoon.
I ask questions on behalf of the COVID-19 Bereaved Families for Justice Cymru. The single question I have for you relates to asymptomatic testing in care homes, which you've already touched on some aspects of in your answers. Could I refer you, please, to an email from Margaret Rooney, the Deputy Chief Inspector of Care Inspectorate Wales, on the 24th of April 2020, which is at INQ 000198311. This email sets out Ms Rooney's views about the need for asymptomatic testing at that date, and states, in terms of the global testing, having read the document entitled COVID-19 in Care Home Settings, Enhanced Prevention and Outbreak Management, and heard feedback from the other inspectorates, in particular Scotland, about staff with no symptoms testing positive, I think all staff and residents in care homes should be tested, whether they are symptomatic or not, and in truth, these tests need to be repeated at regular intervals. Appreciate the capacity to do this needs to be there, but I think the situation seems to have escalated to the point where this sort of intervention may be warranted. Mr Heaney, I think I'm right in saying that very shortly after this email, that statement was broadly in line with your own personal position. Is that right?
Yes, I think I actually might be earlier in this email chain, but I could stand corrected. And, certainly I was asking very similar questions to my colleague in Care Inspectorate Wales. Yeah.
However, the First Minister, Mr Drakeford, took a different view and repeatedly stated on the 29th of April and the 6th of May in the Senedd that there was no clinical value in asymptomatic testing. And my question for you is, are you aware of any scientific or ministerial advice at this point in time that stated that routine testing in care homes had no clinical value?
I am aware of advice going up to the Minister. Certainly aware of advice that went up in detail on the 30th, I think, of April. that went into a wide range of considerations and was quite open actually in some of the changes in the science, but where we were. So the comments that the First Minister then was making and the Minister were making were based upon the advice that was still coming to them. As I mentioned earlier, the critical determination around the change in decision then happens on the 12th, 13th of May, with some real clarity coming forward that then just supported the earlier thinking that was around in some parts, if that makes sense. I hope it is.
It does. It's helpful. Thank you. Can I just clarify, Mr. Heaney? You're not saying that the ministerial advice of the 30th of April indicated that asymptomatic testing had no clinical value, because that was an advice that contained studies such as the Public Health England Easter 6 study.
Yeah, no, and it wasn't, you know, I know who wrote the advice, but that advice was very thoughtful and based upon the medical advice and the scientific advice at that time.
Thank you. Thank you, my lady.
Thank you, Mr. Stanton. Ms. Morris, you should be just slightly to your right. There you are. She's probably standing up.
Thank you.
Good afternoon, Mr. Heaney.
Good afternoon.
I ask questions on behalf of the COVID bereaved Families for Justice UK. I have 3 short topics for you, please. The first is touching again on the care home action plan.
Yes.
Miss Cecil King's counsel ascertained with you this afternoon that Miss Herclots had called for a care home action plan in April. And by the time it came out in July 2020, it was coming out as restrictions were being lifted. So why had it taken till July 2020 for one to be issued?
So the Deputy Minister for Social Services agreed in June 20 to develop a care home action plan. Before that date, we were active in the actions and busy in the actions, but we just really didn't have capacity at that particular stage to go into a care home action plan. As soon as the Minister felt that was the right thing and the timing was right, we did that. But that is not to say that actions that ultimately you will see taking place weren't taking place, because they were.
So Helena Herclots,
Yes.
the then Older People's Commissioner
Of
for
course.
Wales, told the inquiry yesterday that she was told initially by the Welsh Government that the plan would add, quote, no value. And she said yesterday that she found this disappointing and didn't address the urgency of the issue. So why did the Welsh Government feel that that plan wouldn't add value?
So I think I would ask us perhaps on this one to go back to the original letter that the Deputy Minister sends to the Older People's Commissioner, because I do not believe that's what is said within that letter. I don't believe the wording of that letter from the Deputy Minister says no value. I believe at that time what the Deputy Minister was saying was, at this time, will it add value? And it's about discussion, and she didn't write out saying that she wouldn't be doing it in the future. But at that, so I would probably suggest we need to just go back and check the wording of that letter, because I'm not sure that that is a representation of what actually the Deputy Minister and the government was saying.
Okay. I'm not going to take us back to that, because
That's
the
okay.
inquiry had it in front of Ms Herclots yesterday and has had that evidence. But your position is that you don't know whether that was in fact what was being said in the letter.
I don't believe it. And I'm being clear. I don't believe that. I do not believe that's what's said in the way that it's worded within the letter. No, I don't.
Thank you. Second topic, visiting guidance. So between June 2020 and March 2022, you've said that there was 14 versions, so
there was.
13 revisions
There was.
before transitioning to a longer term plan. Do you agree that this amount of revisions would have been confusing for the majority of people, and in particular those who were trying to put it into operation?
I agree that that was a challenge, absolutely. And I think for many families, I know that families communicated with me directly, and I trying to help and explain where we were. So absolutely understand that impact and, you know, really feel for those families as well. What we tried to do to learn as we did was that early in the pandemic, we were issuing it very quickly. So we tried to use, you know, the First Minister's press conferences to lead and to communicate. So we took a little bit of time to explain the changes. And as Council asked me earlier, I think when we went to the alert stage, I think that ultimately become more helpful for families in knowing what could happen. Thank you.
Thank you. Third and final topic, please, sort of protecting the NHS. Ms Cecil gave an example of Every Stories Matter contributor who said that in their view they felt that the Welsh Government put the needs of protecting the NHS from collapse ahead of those in care homes. And in fact, it was the view of Melanie Minty, the Senior Policy Advisor at the Care Forum for Wales, is that the Welsh Government's focus was on protecting the NHS, which had then had a disproportionate effect on the adult social care sector. Now, in March 2020, you attended a COVID core group with the First Minister, where the NHS were projected to reach maximum capacity within 4 or 5 weeks, which you said reinforced the need to take urgent preventative measures to prevent the NHS from becoming overwhelmed. Does that approach confirm that you were in fact prioritising protecting the NHS?
I think it's a really good searching question, so thank you. And pausing and reflecting on it. My thoughts then were, although we used the title Protect the NHS, for me it was Protect the NHS, Protect Social Care. So that was the ethos that I was always working in. And I do believe, and I really do believe this, that we were faced with some really difficult choices. But the capacity within the NHS, you know, having seen the reasonable worst case scenario, having seen the images from Italy in the hospitals, and having understood the kind of conversations that I was involved in, it was actually, you know, I do believe that we were, you know, Welsh Government was trying to support the NHS to be able to deliver to save people's lives. So I don't see it as a straightforward choice of protect the NHS, not protect others. And I really genuinely believe that that was one of the most difficult times and difficult, you know, decisions that anyone had to take. But as you said quite rightly in your question, we had a number of weeks where we knew we would be at full capacity. And having seen the reasonable worst case scenario figures, that was very frightening indeed.
Those are my questions. Thank you, my lady.
Thank you.
Thank you very much, Ms Morris. Now it's Ms Jones, who is probably further to the right of your left of
Thank you.
Thank you, my lady. Mr Heaney, I ask questions on behalf of John's campaign, Care Rights UK and the Patients Association.
Yes.
I want to ask you first about problems of data collection and understanding of the care sector. And you've referred in your witness statement to the data challenges that are faced by the adult social care sector and steps that are being taken by the Welsh Government to improve the collection of social care data, to provide a clearer picture of service delivery and to support your ongoing work. I want to know what challenges did a lack of reliable data about adult social care present during the pandemic, and what are the concrete steps that the Welsh Government's been taking to try to address that weakness?
Yeah, thank you for the question. So, you know, I think, you know, the challenges were around, you know, workforce, capacity in care homes, a whole range of issues from that set of data was difficult. We introduced the care home capacity tracker, if I can call it that, to get an understanding of capacity. That helped during the pandemic. I had discussions with directors of social services early on, and in fairness, I asked for more data at that point, which I think benefited us during the course of the pandemic. I know at that stage some of my director colleagues were uncertain about that, but they did support the direction of travel. We've worked with Social Care Wales to improve data, and we're continuing to work with them. And we've recently developed the National Office for Care and Support, which has a data focus. So very much learning from where we were to improve the data and data understanding.
And are there any specific examples you can give us of problems that you faced due to a lack of data or improvements that would have been possible if you'd had better data during the pandemic?
Yeah, you mean definitely, and a very helpful question. I think for me, it's about, I would have liked to have better data around, the workforce within care homes. We're very fragmented, different owners. I would like to have a national picture of what that looks like, sickness absence and real lifetime data. So I appreciate the challenges, but where we'd like to be in the future is probably in a different place to where we were at the beginning of the pandemic. And we're starting to make some of those tracks now through, as I mentioned, the National Office.
How do you envisage decisions made about the sector might have been different if you'd had that data?
Yes, of course, they could be. I can't say they would be for certain, but I would like to have had that data because it would enable us to have a richer base on which to make decisions upon.
And do you agree that there ought to be a national centralised database of data about the care sector and a system should be established to ensure that data about the sector is complete and accurate and available to decision makers?
Yes, I do. And that's why we've developed the National Office for Care and Support in Wales.
Thank you. I'm going to move on to a different topic now, which is a specific question about the visiting guidance. You've stated in your witness statement that version 3 of the visiting guidance, which was introduced in August 2020, included an integrated impact assessment, which considered how providers could safely facilitate visits while addressing growing concerns about the emotional, mental and physical health impacts of prolonged separation from loved ones. You say that this impact assessment and then the version 3 of the guidance took into account the experience of people living with dementia based on evidence provided by the Alzheimer's Society. And I just wonder if you can help us with exactly how the Alzheimer's Society's position was reflected in the guidance and the impact assessment associated with it.
Yeah, I think I would have to take the detail, I'd have to take that away and really reflect upon that. What I can say more generally, I think is that, some of the reports produced, I read them personally. They were very powerful, very helpful, really raising the voice. What I tried to do, what my team tried to do, was also ensure that voices were widely heard. We commissioned partners to actually being able to raise the voices of individual groups, older people, younger adults as well. Some of those we commissioned through Age Cymru, voices from Care in Wales, All Wales People First. So we used resources like that to really make sure we could, have a richness of understanding lived experience.
Thank you, Mr. Heaney. And that might be part of your answer to my next question as well, which is about the Care Home Action Plan. You stated at para 165 of your witness statement that you wanted the Care Home Action Plan to align with the concerns and recommendations that were made in the Older People's Commissioner for Wales report on care home voices. I want to ask how you ensured that the action plan reflected those concerns and recommendations, and whether you took any steps to obtain the views of people who rely on care in formulating the action plan.
Yeah, thank you for the question. I mean, one of the long-standing traits of the policy area that I work in is co-production, working together with people, heavily involved in legislation and policy over many years. And certainly at the outset of the pandemic, those traditional routes were really troublesome to us, difficult because of the restrictions. And what we did do, we did commission partners to, particularly during those pieces of work that you mentioned, to do that work for us and to feed that through. Separately to that, I also had regular engagement points. I chaired a weekly meeting with lots of partners from the sector, and they were constantly raising up the voice of their particular, populations that they represented, and that was really important and really powerful.
Thank you, Mr. Heaney. Those are my questions.
Thank you.
Thank you, my lady.
Thank you, Ms Jones. And lastly, Ms Beattie. Further behind, Ms Jones.
Thank you, Mr Heaney. I ask questions on behalf of disabled people's organisations, and I'm also asking about the guidance on visits to care homes. So if I can take you back to your letter of the 23rd of March 2020, which you've already been asked about, where you said that visits should only occur when absolutely essential. And as I just understand it, that letter went to all care homes, directors of social services and health boards. Is that right?
Yes.
And you said in the letter that there should not be what you called routine visiting as previously experienced at care homes. Do you agree that that guidance did not expressly accommodate the needs of disabled people who were reliant on visitors, including for daily communication needs? And just to give a concrete example of that, for example, an individual with a cognitive impairment who does not communicate or does not communicate primarily via speech, perhaps, and for whom, therefore, a visitor may be a key interpreter of non-verbal signals and provide key insight into whether they're experiencing pain or discomfort and other health and welfare needs.
And I think that guidance at that stage was at the same time that we went into lockdown. So you're absolutely right to raise that as a concern. That was done with the intention of trying to protect at that particular stage. But I do agree that we would have always, and I think that's what we would support it throughout our care home visiting, was where it was enabled to support, especially people disability, to support. So I think that, from your point is a really good one. I don't think we were intending to, prevent people from being able to communicate. And, obviously I recognise it was a very difficult time.
The letter, I think, probably understandably referred to the importance of emotional well-being and trying to facilitate that.
Yeah.
But, would you agree that what it perhaps was needed was some more formal or structured guidance to care home providers in order to be able to make a decision for an individual about visits that were really essential in order that their needs were met, and so that reasonable adjustments could be made and those needs met and rights protected?
Of course, and I know that partners we work with were offering advice and support, and as I mentioned in a previous question, some of these were the issues that very helpfully were raised with us at the planning and response group by some key stakeholders as well. I recall, a number of illustrations that allowed us to really understand the impact of some of the policy decisions as well that we were taking. And as we revised policy, we were able to take into a wider consideration of some of the impacts.
So looking forward and for any future pandemic or any visiting guidance of any sort, would you agree that that kind of structured guidance is what is needed?
Yeah, I agree. I do agree. I really do.
And in your evidence earlier, I think you said that later on there'd been some really good work across the sector on visiting.
Yeah.
But is it right that the All Wales Forum survey about people with learning disabilities found that even by as late as August 2021, there remained very significant restrictions on visits experienced by people with learning disabilities living in care homes and supported living, with 23% of respondents to that survey not being allowed any visits, 76% only allowed partial access, and only 1% had said that they were able to have full access to visits from friends and family. Were you aware of those results?
Yes, I've read that survey myself. I am aware of those results. And, clearly that's very upsetting, especially given that our policies enabled visiting to take place. So you will see over the different revisions how we have really worked really hard to open up Wales to having, that opportunity of people seeing their loved ones.
But in the case of people with learning disabilities, it seemed that continued to have very long-lasting impacts.
Yeah, no, I'm not disputing that for one moment, and that is something that all of us would want to and should, pay attention to on a number of fronts, not just about pandemic planning, but in terms of engagement on any policy development.
Thank you, my lady.
Thank you very much, Ms. Beattie. Mr. Healy, that completes the questions that we have for you today. Thank you very much indeed for your help. I appreciate the burden it always places on people coming along to assist the inquiry, so very grateful to you. I don't know if you're travelling back to Wales tonight?
No, I'm staying over this evening, my lady.
All right, okay. Well, I won't ask what you're up to. Safe journey back when you go.
Thank you.
Thank you very much. I shall return to start again tomorrow at 10 a.m.
Thank you.
Thank you.